Three, two, one. We are live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor in Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Foxy Symbiosis Webinar 19, Best of Symbiosis Episode 3. Today, the topic of webinar is Medical Disorders in Pregnancy. Before starting the webinar, we would like to have a lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now, I would like to introduce Dr. Monica Singh. Dr. Monica Singh is consultant reproductive medicine, Bhopal Fertility Endoscopy Center. She is professor at LN Medical College, Bhopal. She is managing committee member, ISAR. She is West Zone Coordinator, Medical Resource Committee, FOXY. She is convener of ISAR Perfection Series and FOXY Symbiosis Series. Over to Dr. Monica Singh.
Thank you. Thank you very much, Dr. Vishal, for the kind introduction. And at the outset, I would like to invite you all to the concluding episode of Symbiosis Series. This series, we have included, we have had almost 16 webinars and 3 concluding Best of Symbiosis talks by stalwarts from all over India. And for this particular episode, I have to thank the FOXY Medical Disorders in Pregnancy Committee, chaired by Dr. Manoj Chilani, for the opportunity to collaborate with Bhopal OBGY Society under the leadership of President Dr. Anita Shivastav and our Secretary Dr. Shabana Sultan, in association with our lovely program coordinators. And my thanks goes to all the FOXY office bearers who have joined in today and given their blessings. Dr. Vishal, I'll just give you the audience an outline of the program. We are having 3 talks in this particular episode. The first talk is on hypertensive disorders of pregnancy by Dr. Rekha Rajendra Kumar Madam. The second talk is a very interesting session by Dr. Piki Saxena, who is the National Coordinator of MDIP, focusing on intrauterine milieu for primordial prevention of diabetes. And the third talk would be taken by me on pre and peri-conceptional care. How is it a window of opportunity? So we proceed with the sessions. Before that, I would like to introduce and welcome our dignitaries. We thank with all our heart FOXY President, Dr. Jaideep Tang sir, for always giving us a free hand to do our programs very nicely in collaboration with FOXY. Sir is the soul behind FOXY, the driving force. I would also like to thank our respected Secretary General, Madam Dr. Madhuri Patel, who is so busy 24/7, but she always has, a kind word for everyone, and she tries to make it a point to enter every program as a guest. But right now, she is busy with some family functions. And next, I would like to welcome Dr. Girija Wagh, ma'am. Has she joined, Neetu? Girija ma'am has joined. Kindly give a call to her.
Yes, ma'am. Yes, ma'am. She has not joined yet. Calling
Okay.
her.
So Dr. Girija Wagh is VP West Zone, who is heading the MDIP committee along with Dr. Manoj. We'll welcome Madam when she arrives. And next, I would like to heartily thank Dr. Manoj Chilani, who is not only the chairperson MDIP committee, but also the guest of honor today. So Dr. Manoj, I think we will start with you, or would you want me to start first with our Dr. Komal ma'am? I think we'll start with Komal ma'am.
Komal ma'am. Yeah.
Yes, yes. So first, I would like to have the CV of our guest of honor, Dr. Komal ma'am, who is just, in the car, but she has joined very promptly. And it is a great pleasure to introduce her as the VP of West Zone elect, and also the zonal coordinator for FOXY President 22 to 23. Madam has been a chairperson of FOXY Medical Disorders in Pregnancy Committee in 19 to 22, where she did some wonderful work. She's the governing council member of ICOG, core committee member of VAD cell of FOXY, and also a member and managing council member of MOGS, Scientific Secretary AFG, Joint Secretary ISOPAP Mumbai chapter, and also a national expert on number of FOXY projects like UNICEF Lakshya, Dhira, and RAC convener, FOXY Guinness Book World Record holder for Break Free from Anemia. Madam is a senior DNB teacher and unit chief at VN Desai Hospital, Mumbai, with several awards to her credit, like MOGS Dr. Rishma Dhillon Pai Personality of the Year Award, Foxy Dr. N.A. Pandit and Mrs. Shelja Pandit Women Empowerment Award 22, Foxy Mehru Dara Hansotia Best Committee Prize Award, Foxy Appreciation Award for Valuable Service as Chairperson
Thank
20.
Thank
And
you, Monica. Thank you. I was just trying to
is
adjust the noise,
exhausted.
everything.
So,
So
Madam,
I'll let you go on. So now I can actually talk. Thank you for the lovely introduction, Monica. And when it is a program conducted by Monica and Randir, it is really very a great pleasure to join such a program. And above all, it is a program in association with Medical Disorders in Pregnancy Committee. And I have worked earlier prior to Manoj, and the committee also holds very close to my heart. And Manoj is doing a very fabulous job. And I'm so happy with the work which is going on with the committee. A lot of work needs to be done, and very nicely you all are doing this series of webinar. I must appreciate it on focus topics. And very rightly said, the window of opportunity, yes, when it comes to medical disorders in pregnancy, pregnancy itself is a window of opportunity. A lot of disorders, patient may just come to doctor because she's pregnant, and that is the first time when she comes to us and we diagnose a pre-existing disease, or sometimes a newly existing disease, or something getting exacerbated in pregnancy. So it is really very important to grab that window of opportunity, uh, treat that medical disorder early so that we can ensure a safe uh, whole journey, the antenatal period safely, and then the delivery and everything goes good with the patient. So medical disorders itself is a very vast topic, but hypertension and diabetes definitely, how much we discuss on hypertension and diabetes, it is always the less. A lot of dilemmas and queries keep coming in the mind. So I think you have great speakers like Rekha Rajendra Kumar and Dr. Piki Saxena who would be talking. So this is real great scientific feast. Thank you so much for inviting me. And best wishes to you, Monica, Dr. Asha Jain, all those who have joined, who are contesting for the elections. And best wishes to Manoj Chirani also to do more good work. And I am eagerly waiting to see his work going to the next level in the next year when I take over as a Vice President Foxy. With that note, thank you so much.
Thank you, ma'am, and really looking forward to your tenure as Vice President. Really
Yes.
eagerly waiting for that.
Thank
It
you.
is-
And thank you, Bhopal Obstetric and Gynec Society. I think Shabana Sultan and Anita Srivastav. Thank you for doing such wonderful program.
Thank you.
Thank you, Dr. Komal. Such a rich CV. And we will have a great opportunity and a nice time during your tenure as Vice President.
Thank you. Thank you so much.
Ma'am, your tenure will begin in 25, but the sparks are flying already. I mean,
Already.
your team is already on their toes and really busy with all the programs. I'm seeing the number of RCTs coming up, and Madam is also so active, and Komal Madam
Yes,
also.
yes. Oh, it's
So,
all going. It's all going now. Everything
yes.
with
So thank
flow.
you so
And you
much.
all are the part. You all are going to be the part of it.
I hope so, ma'am. We want to work very closely with you.
Of course, of course, of course.
Yes.
Lot is in mind. Everything. I think September meeting. After September meeting, things we will try to involve and tell you. But everybody is there, and if you feel, you can just feel free to just call me anytime. And we really like people who want to work for Fox.
Yeah, please. Thank you.
Dr. Monica ma'am, Dr. Komal ma'am is in charge of our committee, Medical Disorder in Pregnancy.
Yes.
So really looking forward to it.
Yes.
I know, Madam is very fond of this committee because it was her committee. So I always see that, that love for the committee from her whenever I have this program with Madam involved. So thank you
Yes.
so much, Komal ma'am. And now,
Thank you.
Dr. It is your turn because you are also our esteemed guest of honor. And Dr. Manoj Chilani has also got a very vast CV. He has many firsts to his credit. Not only he is the chairperson of the Medical Disorders and Pregnancy Committee, but he's also the chairperson of Urogynec Committee of IMS. And we have amongst us Dr. Shashi Srivastav, who is just the immediate past president of Bhopal Menopause Society. So he is also the chairperson of Chhattisgarh chapter of ISAR, chairperson of Chhattisgarh chapter of IAGE, vice president of IMA Chhattisgarh 22 to 23, and secretary SOFC Chhattisgarh chapter. He is the managing committee member of ISAR 22 to 23 and the vice president of Chhattisgarh ISOPAB. So, Dr. Manoj Chelani, we are so honored to have you, sir, amongst us as guest of honor, and your committee program too. Kindly impart us your
Thank you.
pulse of
Thank you,
wisdom.
Monica ma'am. Thanks a lot. And first of all, thanks to Bhopal OBGYN Society, Dr. Srivastava, Dr. Shabana. And I'm so proud today that all the coordinators of our MDAP committee are there. Dr. Pikki Saxena, who is national coordinator, will be speaking on diabetes. And Dr. Rekha Rajan Kumar, who is the South Zone coordinator, she'll be speaking on hypertensive disorder. And Dr. Monica, whose favorite topic is periconception, and she is the master of that, so she'll be talking on that. And she's the West Zone coordinator, and all the committee, all the coordinators have really done a wonderful job in the short span of time. We had a series on diabetes, and once these elections are over, we will again start some series on maybe on thyroid disorders or hypertensive disorders. So, it has been really a great year for us, and thanks to all the zonal coordinators and national coordinators, and all the best for the forthcoming election. And hope it's almost like after 48 hours and 6 p.m. on day after on Sunday, we'll have a great this thing. I think by 5 or 5:30 p.m. we'll have the results. And I wish all the best to all the contestants who are here, Dr. Monica, Dr. Asha Jain, and we will have a feast at that time. So today, let's have a feast of knowledge, and all the best. Thank you.
Yes,
Thank
yes,
you,
Dr.
Manoj. Thank you, Manoj. Thank you.
Thank
So
you, sir.
Manoj has already given us the countdown, but we are going to, before the countdown begins, and we are going to have a feast of knowledge. And after that, we can proceed for our weekend. And we are so honored. Now we have, after our brilliant guests of honor, we have amongst us our chief guest. Dr. Tushar Kar has joined. So most welcome. And we are so happy to have you amongst us. So grateful I am that you accepted my invitation at the first call. We know Sir is an accomplished academician. She is heading the Department of OBGY, Professor and Unit Head at SCB Medical College, Cuttack, Odisha. And Sir is the President of Association of Obstetricians and Gynecologists of the state of Odisha. Awarded with FRCOG degree by RCOG London in 22. He is also the chairperson of ICOG 1920, Vice President Foxy 2010, Chairperson Foxy Onco Committee in 2004 to 2009, and National Corresponding Editor of Foxy Journal between 14 to 16. A peer reviewer of International Journal of OBGY Indian Edition, active executive member of ICOG, IAGE, organizing secretary of IAGE Annual Conference in 2016, organizing chairperson ICOG National Conference in 2019, and an esteemed faculty and resource personnel in several national and international conferences, seminars, and workshops. Sir is an avid writer, has contributed many chapters in several textbooks, published more than 50 original articles in national and international journals, and has authored two very popular textbooks called Do's and Don'ts in OBGYN and Safe Surgical Practice. Sir is the recipient of Adarsh Chikitsa Award 2007, Mani Manika Award 2010, Dharnadhar Award 2010, Best Medical Publication of by DC Datta Award 2011, Tarini Pratibha Saman 2015, Best Original Foxy Journal Publication Award 2018, and has his FRCOG by RCOG London and Odisha Leadership Award in 2023. We are blessed to have you amongst us, sir. Such an illustrious personality. We'll be very honored to have your chief guest speech now.
Thank you, Monica. Thank you so much. Am I audible?
Yes, sir, you are.
Yeah. Thank you so much for inviting me, especially for the chief guest of the evening. You know, this whenever you invited me, I couldn't say no. At the same instance, immediately I told that, okay, you keep me. In fact, I am just now, I'll be starting surgery, but still then, I told that, no, I must give some things about whatever the academic activities you have kept. And at the same time, I congratulate all the participants as well as the audience for this innovative idea of Dr. Monica, that symbiosis. And like a medical teacher, this also as a clinician, you have brought the subjects which should be discussed. Like at the greatest example is the SDP, hypertensive disorder of pregnancy, then GDM, gestational diabetes mellitus, and at the same time periconceptional care. Now these three scenario are very, very important for an obstetrician practicing especially, and also for a medical teacher as a postgraduate, also for them it is very much required. And if you see the chronology, the updating of the eclampsia, this gestational hypertension, all these, to start with this terminology, you remember during our postgraduate time, it was called toxemia of pregnancy. Then it changed to this gradually changed to hypertension in pregnancy. Then now the correct terminology, as you know, the NICE guideline, the ECOG, the of course with the ICOG, really agreed for that we must take a broad terminology like hypertensive disorder of pregnancy. You know why? Because it can include all the diseases related to hypertension and pregnancy. Let it be essential hypertension, or it is superimposed hypertension, or it is simple preeclampsia and eclampsia. Everything can be included in this disease, and in the future also, any hypertension related obstetrics that can be included here. So therefore, everybody must know. There is a shift of paradigm in the causation of the maternal mortality of the toxemia pregnancy or hypertensive disorder of the pregnancy. Earlier, whenever you know that in all our state in India, the commonest cause of maternal mortality was hemorrhage. But today, there is shift of paradigm from hemorrhage to hypertensive disorder pregnancy, especially if you think of MP, Central India, Eastern India, especially Odisha, Bihar, Jharkhand, Northeast, and including Chhattisgarh, and also the Central India, the commonest cause of maternal mortality today, hypertensive disorder. Why it happens? You'll be astonished to know. This month, one of the greatest medical colleges in India, SCB, our medical college, having around 18 to 20,000 deliveries. So what happens? Only 2 deaths has occurred. And the near miss case has increased. Only we know that the proportionate a healthy antenatal care institution says whenever it is 1:6, like 1 maternal mortality, 6 this maternal near miss. But in our case, this month it is around 20 near miss case. So we could be able to protect prevent the maternal death only by the appropriate care. And that to do these 2 deaths are admission death interval is only 2 hours. So they have not given us much time. So therefore, this topic must be included. Why? Because we can prevent the hypertensive disorder of pregnancy. So thereby we can prevent the maternal death. And this is the analysis, and this is the how to address that the hypertension disorder. Coming to the gestational diabetes mellitus, it is really unexplained till now. One cannot explain. Even the patient is euglycemic at 34 weeks, 35 weeks, sudden fetal death, IUFD. And then we thought that there is no cause. So we gave the fault to the placenta, individual placenta. Let's say 10 women are there, all are euglycemic with GDM, with insulin, but sudden maternal death occurs to one, not to other 9. So this is again unexplored, and this must be found out. And periconceptional, as you know, recently we have changed the terminology that every pregnancy must be safe. That the woman has come for not safe pregnancy, but for the safe, not safe pregnancy or delivery. She has come for a delivery because our intention is that every pregnant women must be safe in terms of maternal and fetal outcome or fetal-maternal outcome. So therefore, you have taken the topic very rightly, and you have chosen the speaker also, not only the topic, the speakers of high value, those who are the very strong clinician, heavy practitioner, and they can give some input so that the audience and the participant can be benefited. Thank you again, Monica, very much. And I wish every success of this CME, especially in this evening, and as you know, weekend evening, so that everybody can enjoy. Thank you again, and all the best for a good CME.
Thank you. Thank you, Tushar sir. Thank you, sir.
Thank you, sir.
Yeah.
Thank
Thank you, sir.
Namaste.
So your chief guest speech was so apt and so comprehensive. You touched on every topic. You knew the gist of our CME. You have touched upon every topic which is going to be spoken like a true professor. Thank you so much, sir, for your
Thank
kind
you.
words and your
Thank you.
gracious presence. Thank
Yeah,
you,
yeah.
sir.
So greetings to you from Bangalore, sir.
Yeah,
Sir,
yeah. I'm so happy,
Namaste,
delighted.
sir.
Yeah, yeah.
Thank you, sir.
Thank you. Thank you.
And Dr. Neetu, can you do the
Yes, ma'am.
honors?
Good
Mobile
evening.
obit-
Thank you, ma'am. Thank you, ma'am. Good evening, all. Now, it is my proud privilege to introduce the President of Bhopal OBGYN Society, Dr. Anita Srivastava, madam. She is alumni of Government Medical College, Jabalpur and Gandhi Medical College, Bhopal. And she has played a role of Vice President, past Treasurer in Bhopal Menopausal Society, Secretary, Joint Secretary in Bhopal OBGYN Society.
Enough,
She is
Neetu,
very
enough.
she is very dynamic president of our society, and we have really grown to such a level. And this has been shown in recent Bhopal VPCon conference, which was a great success. Now, few words from you, ma'am, please.
Good evening, everyone. We all welcome you from Bhopal Society. It is a very nice weather outside, raining heavily with all the greenery here. And I think this is the last episode of our Symbiosis series, which was started under BOGS by Dr. Monica Singh. It was a very nice series. She covered each and every topic. She searched each proper candidate to speak upon on each of the topic and to elaborate everything in a very nice way. We had nice discussions with all the stalwarts from all over India, and now she is competing for the post of chairperson in perinatology, and I wish her all the best for that. And I hope you all have voted for her, and we'll have a nice treat day after tomorrow from Dr. Monica. And I wish she'll start new series with all of us, and we can do much more in webinar section later on also. All the best, Monica. Thank you for inviting us, and we'll now have nice treat of academic now.
Thank you, thank you. And Anita Didi is like my very close to me, and she always speaks from heart. She always speaks. She encourages juniors. She's very loyal to Bhopal OBGY Society. That I know, and she wants each and every member of Bhopal OBGY Society to spread their wings.
Yeah.
That is the true leader. True leader is like a chhatra chaya. It's like a bargat ka ped, every like that person should support everyone and let everyone grow. Thank you so much for your presence, Madam President. And
Thank you, Anita ma'am. Thank you. And it was fortunate to work under you in this VPCon conference, which was a great successful. And we hope that many great conferences will be holding in Bhopal.
Yes, yes, we'll do more work.
so
Thank you so much, ma'am. And we have equally dynamic Secretary of Bhopal OBGYN Society, Dr. Shabana Sultan, ma'am, Professor and Head of Department, Gandhi Medical College. She will not be able to join because of some prior commitments. And now we have
So now
two
I will now introduce our program coordinators. We have got three very, very dynamic. We have we have co-convener, Dr. Randhir is
conveners,
there.
ma'am.
So my support system and my co-convener always beside me and walking step in step so that the programs go nicely. And a very active Isarian and embryologist. And we thank you, Dr. Randhir, for your support and good wishes. And now I would like to thank our very, very sweet and hardworking girls who are the program coordinators, because everyone young is like a little girl to us. So Dr. Neetu Mishra is actually Associate Professor, Department of OBGY at the prestigious AIMS Bhopal, which is one of the premier institutes of the country. Very keen academician. Can I have her CV? So she is the recipient. She belongs to, I think you belong to Burla, Neetu?
Yes,
Yes.
ma'am.
She
Yes,
is a very active member of ISOPAB also, recipient of Jagdishwari Mishra Award and winner of quizzes Ekamra Meet Annual State Conference of OBGY. She has participated as investigator in SSI project at PGI Chandigarh, also preconceptional counseling and care project at Safdarjung, Delhi. She has presented many original papers and book chapters, more than 20 from what she last told me, and an original paper on the role of HSCRP as a marker of severity in PIH, which will be relevant today also. Thank you, Neetu, for all your help in Symbiosis.
Thank you
Next,
so much, ma'am.
I'd like to thank and acknowledge the great work and commitment of Dr. Purva Bhatkur, who is Assistant Professor in the Department of OBGY at GMC Bhopal, my alma mater. And she is also a computer wizard, and she is a national accredited trainer for ISCCP colposcopy training course. Presently, the divisional convener in MPSC AGOI, and her special areas of interest are high-risk obstetrics, preventive oncology, infertility, antenatal and gynecological ultrasound. She has been national faculty speaker. She has more than 20 original research chapters and publications. Thank you, Dr. Purva, for always being there.
Thank you so much, ma'am, for your kind words.
And next, I would like to introduce our third brilliant coordinator, Nandini Singh Bhati, who's also working as assistant professor in the Department of OBGY at GMC Bhopal. She is trained in high-risk obstetrics, antenatal and gynecological ultrasound. She is especially interested in reproductive medicine and gynecological malignancies, and a very soft-spoken and always, helpful girl. Thank you, Nandini.
Thank you, ma'am. Thank you so much. It's a privilege to work with you. Thank you. Thank
So
you.
we start our academic sessions, and over to the coordinators to take it forward.
Thank you so much, ma'am. Now we will move ahead with our scientific session. First session will be by Dr. Rekha Rajendra Kumar, madam. She is president of Bangalore Society of OBGYN. She will be talking on hypertensive disorders of pregnancy. To chair this session, we have two dynamic and learned faculties, Dr. Asha Jain, madam. She is president of Raipur Menopause Society, and Dr. Varsha Lahade, madam, past president of Nasik OBGYN Society. Dr. Asha Jain, ma'am, she has more than 3 decades of experience and director of SMSA Hospital, Raipur, medical director of Cancer Prevention and Relief Society. She is also elected member of Chhattisgarh Medical Council and zonal chair for Foxy Food, Drug and Medico-Surgical Equipment Committee, West Zone. Madam is also chairman of Mission Pink Health IMA Raipur and executive member of ISCCP. She has also held many important posts in past, like past president of Raipur OBGYN Society, past secretary of IMA Raipur, past president of Rotary Club of Raipur North. We welcome you, ma'am, for your great academic inputs in this session. Dr. Varsha Lahade, ma'am, is immediate past president of Nasik OBGYN Society, and she will be joining in between. She is in another webinar and will join in between the talk. Now over to our chairperson to introduce our speaker, Dr. Rekha Rajendra Kumar, madam, and carry forward the session, please.
Thank you so much, Dr. Neetu, for that very kind introduction. Now it is a privilege and a pleasure to introduce my dear friend, Dr. Rekha Rajendra Kumar, ma'am. We've done a lot of work together. She's the medical director of Miracle IVF Hospital and Chandana Hospital, Bangalore. She is a gynecologist and IVF specialist. She's been practicing almost as long as me, practicing for the past 33 years. And she's currently the president of Bangalore Society. She has been an overachiever from the beginning. She had a first rank in MD, university examination, 7th rank in MBBS examination, all India topper in the ICOG reproductive medicine examination. She's an invited faculty in more than 1,000 state, national, and international conferences, organizing chairperson of FemPower National Conference, which we just attended in Bangalore, and it was so good. She's a peer reviewer of Jogi, 21 awards, 7 felicitations, ex-PG teacher of MS Ramaiah Medical College and Bangalore Baptist Hospital. She has 27 original articles, 1 case report, 1 poster in ESHRE Europe 2021, and she has more than 100 radio and TV talks, 100 camps, 40 newspaper articles, all on women's health. So we are eager to listen to you, Dr. Rekha. What is not written here is she's also a very accomplished Bharatnatyam dancer. So welcome, Dr. Rekha.
Thank you so much, Dr. Asha, for such a detailed CV presentation of mine. First of all, I acknowledge thanks to Dr. Monica Singh, Dr. Ranbir, Dr. Manoj Chelani, first of all, being the chairperson of medical disorders, Dr. Komal, Dr. Asha. And in the very beginning, I would like to send my best wishes to both the contestants, Dr. Monica and Dr. Asha. I really wish from the bottom of my heart that you both come out with successful colors. With that, I start my presentation. Please allow me to share my screen. Yeah, thank you so much. The topic I'm talking today is on hypertensive disease in pregnancy. I'm touching upon only the current status and the future concerns. Coming to the brief introduction about the topic, the hypertensive disorders of pregnancy, it is the one that globally affects up to 10%, which is a big magnitude of all our pregnancies, which we see in the outpatient department. The prevalence of this, that is HDP, was 7.8%, but the preeclampsia, the niche kind of that, is around 5.4%. And all of you agree with me that the burden is greatest in the lower or the middle income strata. The early identification results in better monitoring. We will be wiser about that patient in the management so that her obstetric outcome and the neonatal outcome is much better. Coming to the types or the some subtypes which I have mentioned here, listed here, do overlap, like chronic hypertension, like essential hypertension or the chronic hypertension, almost one and same. Secondary hypertension, white coat hypertension, patient may be having this already, or certain of them may arise de novo in pregnancy, like transient gestational hypertension, which disappears in the puerperial or in the late puerperial period. The preeclampsia, de novo, or maybe superimposed, as I have already told, with any of the ones which I have mentioned and listed above. Coming to a broader classification, depending upon the gestational age, the classification is if the gestational age is less than 20 weeks out of the 40, less than 20 out of 40, it happens in chronic hypertension, it is detected. What I mean to say is chronic hypertension is the one the patient comes to you with that in the very first visit. So it is definitely detected much earlier in the first half of the pregnancy, and most of the times there is no proteinuria. This is for the beginners, the undergraduates who have logged in. It's a rough classification so that you come to some kind of conclusion about this patient, about the etiology or the subclassification of hypertension. The second one would be the hypertension due to renal disease, not so common, but again that is detected in early part of pregnancy because she has come to you with the renal problem and the hypertension is detected. But the difference here is she comes with the proteinuria, which is quite significant, more than 0.3 grams per dl. The gestational hypertension or the PIH is usually comes in the second half of pregnancy and no proteinuria. Preeclampsia or PET, the term is getting obsolete, rather more than 20 weeks and proteinuria is there. So this is a rough classification. How do we diagnose? Come what may, our diagnosis depends upon the blood pressure monitoring, which is the first important finding to make the diagnosis. That is why our regular day-to-day use of the handy equipment, that is mercury sphygmomanometer, and other devices need to regularly validated and calibrated. Correct size of the cuff is important. It is, I don't have to say this, it is a very important fact because that is one of the important parameter which changes the blood pressure in that woman. It may have atypical manifestations with the normal blood pressure. Now coming to the spectrum of the pathology, rather it is the preeclampsia is a spectrum of pathology rather than a single disease. It is diagnosed when the blood pressure is more than 140/90. It's a borderline kind of blood pressure or more after 20 weeks of gestation. It is after 20 weeks of gestation on two separate occasions. at least 4 hours apart. So this is one combination. Or the second situation is one direct reading of more than 160, 110, because it's a gross hypertension which anybody can detect, and you don't have to have a second reading. The second reading after 4 hours, after resting, whatever, is not necessary because it is glaring at our face with her gross hypertension plus the significant proteinuria. So the combination of a higher degree of blood pressure with the significant proteinuria is a second situation where you make a diagnosis. There may also be evidence of other end organ disease in this. It is needless to say. Edema can happen, which is fortunately or unfortunately a normal finding in up to 80% of the pregnant women. Therefore, it tends to be more significant if you look for degree of edema carefully, like the location or where it is there, like the facial puffiness or the sacral edema is more significant because it is in unusual site, unlike our regular pedal edema. Now, the magnitude of the problem, the two areas which we have to think about this magnitude of the problem is one, the prediction. Like it is very important for us to predict. That is where our intelligence lies. The second thing is the long-term consequences of this PIH, because most of the times the blood pressure comes back to normal once she finishes her delivery, that is postpartum, maybe about 6 weeks, her blood pressure comes back to normal and the patient forgets and we forget about these long-term consequences. So these are the very two important things where the current status and the future of this HDP lies. Coming to the etiology, it is not completely known. All of you definitely agree with me, but we have a confounding fact that the placenta is the culprit. It is the disorder of placentation, like failure of the adequate trophoblast invasion at around 15 to 16 weeks. That is the time the placenta should erode, bury, and go down. It is the overriding pathology is the systemic vasospasm that is added to this disorder of placentation. That is the second problem. The systemic small vessel abnormalities, that is the microangiopathy, can happen other than the vasospasm. There is increased endothelial cell wall activation of the platelets. Ultimately, the microthrombi are formed. The blood circulation to the end organs is not there. Capillaries are not well perfused. So there is an infarction of the end organs. Additional problem can be the capillary vessel wall integrity is not maintained, so the permeability is more in these capillaries. So there is a diffusion of fluid from the intravascular space to the extravascular, thus causing our other problems like edema. So it is a two-stage disorder. Stage 1 is the per se problem lies in the placenta. In stage 2, it is a maternal response which is secondary to the placental disorder. So ultimately, all of you agree with me on this page that the pathophysiology of hypertensive disorder of pregnancy is very complex. It may be placental, it may be a heterogeneous disorder, multifactorial, immunological, genetic, whatever you call. So the two-stage disorder, as I was mentioning in my previous slide, is first is a more grievous situation. That is the early onset of PIH. It happens much early, very early stage, say 24 weeks, 25 weeks of her pregnancy. So that will result in IUGR, of course, because it has appeared early. The organ dysfunction in that woman can happen. There is a release of SFLT1 cytokines, and all the immunological reactions are very severe in this. The second stage, what I was talking, is the maternal response, and the term PH can happen because of this maternal response, but it happens at a later stage, by which time the baby has already escaped. The IUGR part is not there, but there are certain things like edema, as I was mentioning, hypertension, vasospasm, leaky capillaries, and the multi-organ disorder can happen if it is a severe kind of PIH. Coming to stage 1, in normal pregnancy, the narrow, highly contractile spiral arteries in the decidua basalis, it is a decidua basalis, and the myometrial junction are remodeled. extravillous trophoblast invades the maternal blood vessels that results wide bore low resistance vessels, and they deliver large amount of maternal blood. This ensures as adequate fetal perfusion like compartments
Madam is not audible. Monica?
Ma'am, you have muted yourself.
No,
Dr.
no.
Rekha?
The
okay,
slides.
okay. Yeah, it went, yeah. Am I audible now?
Yes, ma'am, you can
You're
share
audible,
again.
but we
Sorry.
can't see the slides also.
Oh my God.
No,
It
ma'am,
was
you
Cached.
can share again, ma'am. Take your time, you can share again.
it was visible all this time?
Yes,
Yes,
ma'am.
yes. It just went, madam. 1 second back. 2 seconds back.
So fine. I will share again, right? Yeah, 1 minute, please. Please allow me.
Varsha Lade ma'am has joined. Welcome,
Yes,
Dr.
hi.
Varsha.
Hi, hello. I'm so sorry.
Hello,
for the
Dr.
late-
Varsha.
Thank you so much, Asha Jain, madam. Hi, Monica.
Hello, ma'am. Hello.
I'm in Hyderabad. Hi from Hyderabad.
Hi. Good
How
evening.
should
Dr.
I share again? How should I
Yes.
share again?
Yes, ma'am.
Yes, madam.
Is it seen?
No, ma'am, it's not seen. Ma'am, you have to stop share and then share again. Are you still?
The stop share option is not there now.
Ma'am, one thing you can do is leave the meeting and enter again, madam.
Okay, fine. Yeah,
And
I'll do that.
we will wait for you, ma'am.
Yeah, very sorry. I don't know.
No, it's okay, ma'am. Sometimes maybe the weather and all, no? Rainy weather.
I know.
Ma'am, you can leave the meeting and join again from your
I'm
email.
trying that nothing is coming. Nothing is coming. Trying to leave the meeting.
Lower right corner, madam. Lower right corner of your.
Yeah. That was not showing.
Yeah. So, ma'am, is it rainy weather in Delhi also, Picky ma'am?
No, today there was no rain.
Okay.
Rain in some places, but not at my place.
Yes.
So belated happy birthday, Dr. Piki. What did you do on your birthday?
Oh, thank you. Thank you, ma'am. How did you come to know?
WhatsApp Zindabad.
Belated happy birthday, Picky ma'am. I didn't know.
So what did you do yesterday?
Nothing, normal hospital. Then there was a DGF conference. I went there and celebrated with family.
That's the best celebration.
That's the best thing. Dr. Manoj ने join किया है क्या? I'm
Yeah. Dr. Manoj was there, madam, right in the beginning. Now I think he's
still there, right under you on the screen.
Yeah, he.
So Rekha madam has joined again.
Yeah, Rekha ma'am has joined.
Ma'am, you're muted, Rekha ma'am. Now you can start sharing again, ma'am.
Yeah. I'm doing that.
We can see your slides, ma'am.
Yeah. Thank you so much for bearing with all this.
Ma'am, it's okay. We have a lot of time, ma'am.
Yeah. Is that seen?
Yes,
Dr.
ma'am.
Monica?
Very
Fine.
good.
Thank you so much. I think I was here. There are 3 compartments which all of us know. First is the non-pregnant compartment, which is not relevant here today. And second thing is the compartment where it is a pre-eclampsia. Look at that horizontal dividing line between the decidua and the myometrial boundary. This is the zone, this is the line which is between the decidua and the myometrium. The trophoblastic invasion in PIH stops inside the decidua. It does not go to the myometrium level. It does not cross the myometrial boundary, that zone in between border, it does not cross. Whereas in case of the normal pregnancy, the perfusion is so much that the trophoblastic activity goes beyond the decidua and reaches the myometrium, and the vessels are also not that tortuous, and thus ultimately the trophoblastic activity is good and the perfusion is better. This is another important indication that we make out. The ultrasound shows the uterine artery notch in more than 22 weeks in case of PIH. In early pregnancy, the notch can happen, but if it persists more than 22 weeks, think in terms of PIH. So that was stage 1 about the two things, the myometrial perfusion as well as the uterine Doppler. The stage 2, it's a key hallmark is maternal endothelial dysfunction in stage 2. Maternal intravascular inflammation does happen here. The leukocyte complement clotting system activation happens. There is an increased permeability of capillaries, which I have already mentioned. Thus, the fluid leaves the intravascular compartment. There is an increased vascular reactivity, vasospasm happens, the balance between the vasodilatory prostacyclin and the vasoconstrictory thromboxane gets tilted. There is more of a vasoconstriction elements, and there is a release of the platelets and the endothelials of the vessel walls. So it is a multi-system disorder. It can involve not only the placenta, it can involve not only the fetus, the uterus, but outside the pregnancy compartment, like the kidneys, the liver, central nervous system, coagulation system also. The problems with PIH are: one, it is difficult to predict, because you really don't know which are the other organs affected other than our placenta, the fetus, and the uterus. When and which other organs would be affected in future though the patient is under strict monitoring, and how quickly the organ functions can deteriorate. I don't know when her creatinine is going to rise, when her BTCT is going to fall. So the early onset versus the late onset. PIH. Early onset preeclampsia is usually defined as preeclampsia that develops before 34 weeks of gestation, whereas late onset is 34 or beyond. Abnormal placental development is believed to be more strongly associated with early onset, whereas late onset is believed to be secondary to maternal microvascular disease or reflect a maternal genetic predisposition. So we are happy if she comes to us, if not PIH, even if with PIH, if it is a late onset PIH, like more than 34 weeks, it is much better situation for us. In early and preterm preeclampsia, the baby and mother experience more complications naturally, and maternal mortality is more compared to the later ones. The intrapartum maternal complications in preterm and early preeclampsia are more like our accidental hemorrhage. Lifelong complications to the newborn also can happen, and the mother also. Baby can have the growth restriction, and it's called as an epigenetic disorder. So diabetes, obesity, cardiovascular disease, and whatnot can happen in that baby if it is affected with early preeclampsia. So hence, we want to have the certain markers and which we can predict the preeclampsia. That's a preterm preeclampsia. There is a significant reduction of preterm preeclampsia possible with the treatment if we start the aspirin before 16 weeks of pregnancy with the dose of 150 milligrams of aspirin. Coming to the risk calculation based on the clinical factors, it may be genetic factor, as I have mentioned. There are certain supporting factors which say women whose mothers had PIH develop to the extent of 20 to 25%, even more if her siblings are affected with PIH. The obstetric factors: primiparity, adolescent pregnancy, the multiple pregnancy, hydrops, because the placenta has a large surface to occupy, hydrated form. These are the obstetric events which are more connected with PIH. The other medical factors like already existing chronic hypertension, renal hypertension, essential hypertension, obesity, diabetes, or APLA syndrome, all this can be closely associated or maybe the sister concerns of PIH. There is something like dystosis score here. We do give a score, what we call as a relative risk for PIH. Like if it is a nulliparous woman, the risk stands as 2.9, age more than 42, family history 2.9. So we can add all these and come to a conclusion that how much of risk she is suffering from. That is the prevalence of PIH. The physical parameter screening, the uterine artery will provide a quantifiable risk factor. The use of uterine artery Doppler as a screening tool for preeclampsia and IUGR remains controversial due to low positive predictive value for term disease, term PIH. But in the prediction of preeclampsia requiring delivery before 30 weeks or the early PIH, Doppler at 20 to 23 weeks gestation performs well with the several large studies, and they show that Doppler has helped in the diagnosis as a physical parameter. I have already mentioned about the uterine artery Doppler. This is the normal way. This is the one with the increased resistance. Now, why all these screening parameters? Why do we want to know which are the ones like the past history, her family history, her medical history, the genetic disorders? These are all the predictors, I can say, or the screening parameters like the Doppler, the biochemical parameters. So many we have left no stone unturned in screening these women. The mean arterial blood pressure, diastolic, plus the combination of systolic minus diastolic divided by 3. The blood pressure, checking the blood pressure also is very important for the undergraduates or the postgraduates who have joined here for this talk. It is a very important way of checking blood pressure. An automated device should be used, and this should be calibrated at regular intervals. The woman should be in a seated position with her arms supported at the level of the heart. A small cuff, normal cuff, or the large cuff, depending upon the mid-arm circumference. A rest of 5 minutes is necessary, and then check in both the arms, and a series of recordings are made at 1 minute interval until the variations between the consecutive readings fall within 10 millimeter. Like the difference should not be much in systolic and the diastolic blood pressure, which should be less than 10. The mean arterial pressure should be calculated for each arm as an average of the last two measurements. The arm with the highest final value is considered. Other than the blood pressure, we do have other biomarkers which we bank on for screening or for the early detection of these high-risk women. There is no single biomarker which has shown to be sufficient clinical value. Probably the blood pressure regular recording with whatever details I have mentioned in the previous slide is better most of the times, especially in the low resource settings or the remote areas than the biomarkers. Of course, if you have the facility of biomarkers, you can make use of that, but there is no exact single biomarker that has emerged. The placental function can be evaluated by analysis of the placental-derived peptides in the maternal serum. In women who develop preeclampsia, first trimester serum levels of PAPA or the pregnancy-associated plasma protein A and plasma protein 13 are reduced. So these are all the parameters. The details or the full form of the parameters are here. These are all the different parameters and the predictive value of these parameters. Like at the age of pregnancy age, less than 34, less than 37, how each one is important. So these are all the parameters. The preeclampsia detection rates for the various combinations of the markers, and don't forget to take her history. Now, these are the other parameters which need some notice here and some attention. VEGF, that's a vascular endothelial growth factor, SFLT1, SVEGFR2, SENG, and PIGF. Alteration in the circulating angiogenic factors have been implicated in the pathogenesis. VEGF, an endothelial cell-specific growth factor, and PIGF promote angiogenesis, which all of us know, acting through the tyrosine kinase receptor. SFLT1 which is a variant of VEGFR1, binds to the circle. Look at this sentence. This is important. It binds to the circulating VEGF and PIGF, and it prevents their interaction with the endothelial cell receptors, especially inhibiting the VEG stimulation. It acts opposite because it binds to the VEGF. So it inhibits the VEGF stimulation of the nitric oxide system through the EGFR2. So SFLT1 has been shown to be elevated in pregnant women with preeclampsia, and there are many studies which say that it is one of the important parameters, and it is accompanied by the decreased levels of free VEGF because it has bound to that. Now, coming to certain complications, further research and large prospect studies on prediction and prevention are needed to avoid all the complications. These are the maternal complications, and the incidence is this much and can happen. The maternal complications are important ones are abruption, DIC, acute renal shutdown, pulmonary edema, the aspiration, and the unfortunate event of maternal death. The fetal complications with the incidents are placental abruption can result in sudden death of the fetus, sudden operative intervention, intrauterine retardation, prematurity if mother is increasing in blood pressure and getting the end organ damage or any other complication, we may have to deliver that baby, and because of this, the compounded result can be the perinatal morbidity or the mortality. So this is a hub of all the complications or the events that happen here and ultimately resulting in the maternal death. Maybe the end organ disease like the hepatic disruption, the renal failure, thrombocytopenia, the hypertensive encephalopathy, whatever, ultimately resulting in maternal death. The fetal complications, it can go like this, like the hepatic glycogen stores are reduced, redistribution to vital organs and the brain is spared most of the times, reduced abdominal circumference, sparing of the head circumference, and oligohydramnios, asymmetrical seizure, whatever we talk of regarding or secondary to the hypoxia and reduced fetal nutrition, thus another unfortunate event of fetal demise. So the long-term outcomes, the risk of developing gestational hypertension in a future pregnancy should not be forgotten or ignored. So that ranges from 1 in 8 or 13% pregnancies. So it is our duty, like GDM, when the postpartum lady leaves our premises, we have to tell her, don't forget to buy a sphygmomanometer. Check your blood pressure with the digital because it is more friendly for the patients. Check your blood pressure with digital sphygmomanometer, and you have to keep checking. Don't forget, it is not the next pregnancy that opens the chapter of the prediction of gestational hypertension. You should be aware of this all the time. So preeclampsia in a future pregnancy is up to about 1 in 6 pregnancy, and that's quite high. And in future pregnancy, it's about 1 in 4, that's a 25 pregnancies. If their preeclampsia or PIH was complicated when it and in the form of a severe or a fulminant form, or the other additional complications like the HELP syndrome or the eclampsia or a very early preterm delivery. So the chances are much more in these cases. The long-term prognosis, the data on the long-term outcomes following the PIH pregnancy suggests that it is not a benign and resolvable condition, unfortunately. It may be a manifestation of the underlying propensity for the later cardiovascular, because we always talk about the endothelial dysfunction. We always talk about the end organ problems. So it is the spectrum that tilts between these two. So it may be the cardiovascular, cerebrovascular, renal, diabetes, and cognitive dysfunction also one should remember. So it's no longer solely a pregnancy disease. So it is not only the obstetrician's headache. The onus lies on other departments also, like coronary vascular disease, the stroke, thromboembolic events, premature death. I have already mentioned all this. There are some studies which show that the thyroid disease also is affected, the neurocognitive and psychological disease, and to our surprise, even the cancer. So these are all the different parameters. I mean, different complications that can happen. And on the right side, the relative risk also is mentioned. So another important event, the unfortunate event that can happen is the cardiac function is because the cardiac function is affected, there may be early death of these women. The lifespan of these women may be lesser. In the sense here in this graph, it shows the vertical arm shows the survival of the mothers, that is the number of survivors, and on the x-axis it shows the number of years from the first birth, like how many years she is going to survive. Say at the 20 years, the last one I'm reading, 20 years is the number of years from first birth. Like if she survives for 20 years, then the chance is much less. Like the survival of the mother is much less. That is what I want to say. The preeclampsia and CVDs may develop by the common pathophysiological pathways initiated by similar vascular risk factors, and it's a common factor, and that's why it may be like preeclampsia or CVD or a combination of both. It may provoke the permanent cardiovascular damages, which may be an independent contributing factor to the development of future CVDs. Maybe an enhanced atherogenesis can happen in these women. The myocardial damage also is more not only the vasculopathy of the heart. This data suggests that PIH may be associated with the potential for significant myocardial damage, also as supported by the Doppler studies of the myocardia. The long-term outcome can be modified by the early antihypertensive therapy. In this picture, the image I'm showing on the right side, look at that. It is the yellow arrow mark is showing the septal bulge. The septal bulge is because there is a failure to compensate, and that results in increased wall stress. It is very difficult to say that it is whether it is per se because of PIH, whether it is because of the overriding chronic hypertension or the preeclampsia as such, and the associated other problems which I have mentioned, like the myometrium not functioning properly, the pumping action of the heart is not there, and the blood vessel spasm, etc., where the hypertension develops and the heart has to work more, and there is a myometrial hyperplasia. The myocardial hyperplasia, I'm sorry. The preeclampsia and the offspring health should not be neglected. It is not just the mother. If born preterm, it may be with or without IUGR. The baby may also have the chronic lung fibrosis, cerebral palsy, learning disability in the schooling, type 2 diabetes, pulmonary hypertension, CVD. The list is endless. So the baby can also get overshadowed by the maternal problem. So the onus on us is all the more to detect the hypertension at the early stage as well as to keep it at bay. If born at term, it is protected from the cerebral palsy, but rest of the things like the inflammatory, endocrine, or metabolic problems may continue. So there are many studies which say that the brain also gets affected. There's a presence of the white matter regions on the cerebral magnetic resonance imaging is being shown. So it says preeclampsia may be a risk factor for the permanent cerebrovascular damage. So in addition, there is a growing evidence that preeclampsia may be a marker for the long-term health risks. So here it is a bit different what he says, that is John T. Repke. He says that neither first trimester serological screening nor second trimester uterine artery Doppler velocimetry clinically useful for predicting preeclampsia in these low-risk populations. He's talking about the low-risk populations. I also would go one step further and state that without some proven effective intervention beyond what we already have, that is the clinical judgment, implementing a screening test for preeclampsia is of minimal to no use. So clinical judgment is very, very important. In future years, it may be possible possible to offer women at 12 weeks of gestation a combined screening test that early, involving quantification of the fetal nucleic acids and angiogenic markers and ultrasound assessment of uterine PI to quantify accurately their overall preeclampsia risk. So you have to catch them as young as 12 weeks pregnancy. Measurement of capillary density as a predictive test is a possibility. The treatment part, the aspirin and calcium, all of us do agree on that page, and all of us do start much, much early. Agents capable of substituting for the deficiency or inducing the activity of heme oxygenase system and or reducing the elevated SDFLT1. So it is a ultimately, we want to reduce this SDFLT1, may have therapeutic potential for alleviating the severity of preeclampsia and in turn prolong the pregnancy in early onset disease. Arginine, the antioxidants, the various vitamins, the new kid on the block, what we always talk or the buzzword for everything is the probiotic. So I'm in the last few slides. The learning points are hypertensive disease in pregnancy, especially PE is extremely variable in its presentation and severity. We should be wiser and wiser to catch it if it is in any nook and corner. Every year, several young and previously fit women die because of this problem. Once diagnosed, the disease will invariably progress. Which organs, when, how quickly to predict is left to our imagination. Only cure is delivery, that is removal of the placenta, because placenta is the culprit. Prevent and control of fits, control of blood pressure, etc. are important with concurrent delivery of the woman. Early prediction should be reproduced and it need not be repeated because it is that important. Long-term consequences need to be considered. The two case presentations which I have put here are little bit, one is different from the other. It is the first one is a 34-year-old woman, G3P2L1 with 1 IUFD, now 6 weeks by dates and 6.3 weeks by scan. There is no history of bleeding per vaginum, no history of any medical disorders or the surgical problems. So P1L1, it's a female, 6-year-old. She has one baby, 6-year-old by LSES for non-progress of labor. Second one was a IUFD male at 29 weeks. The section was done because of severe preeclampsia and it was a previous LSES. G3, now she has come at 6 weeks of pregnancy. In the last pregnancy, patient had eclampsia as a severe preeclampsia, with IUFD with premonitory symptoms with DIAC and HELP syndrome add to the problems. She was treated, but as symptoms subsided after the delivery and blood pressure returned to normal, as I have reiterated before, no treatment was continued at home and she completely ignored and forgot her problem. The post-pregnancy investigations were done and now she has come with no pallor, no edema, all the systemic examinations are normal and PV, no active bleeding. What would be the plan of action? Consider the antihypertensive therapy only if BP starts raising and that needs strict monitoring and early detection. Monitor BP at every visit. Rule out chronic hypertension by whichever investigation you want to do. Routine blood investigation, uterine artery and umbilical artery Doppler at 12 and 20 weeks. Start aspirin, 150 milligram tablet aspirin from 12 weeks till delivery because you already have the history till delivery. It should be given, can include, should include rather, elemental calcium supplementation with magnesium and zinc, vitamin D3, and other nutrients like folic acid because it reduces the abruption other than B6, B9, and B12. Now she has come with no hypertension. We have caught her very early. So it is for us to make an early diagnosis and detect as early as possible with the treatment, whatever I have mentioned. She has not got into PIH, but she has a very strong history. This is a second case where she is a second gravida with one live baby and she has come to the labor room at 28 weeks of gestation now, complaining of severe headache and blurred vision. Fetal movements are perceived luckily. There is no bleeding previous was a normal delivery and it's a 3-year-old girl, and the blood pressure in this pregnancy was normal throughout antenatal checkup in this pregnancy, and she has no other issues except for her symptoms. When you have examined her, she has no pallor, no icterus, and bilateral pedal edema is present. Blood pressure is sky high with 2+ proteinuria on urine analysis. Systemic examination normal. Uterus is 26 weeks only, and cephalic FHS is there, os closed, and she is not in labor. She is 29 weeks, but SFH is 26 weeks. These investigations are okay. Fundoscopy, the liver function, RFT, all are normal. So what is your action? Just because of two things. One, her symptoms very indicative of throwing fit. Second, with her very high hypertension. So start IV labetalol, and if BP is not controlled, maximum dose can be given up to 300 milligrams, stabilize the blood pressure, neuroprotective dose of magnesium sulfate, steroids for lung maturation because delivery is around the corner, ultrasound Doppler for the fetal monitoring because already probably the IUGR has set in. If BP is not controlled and premonitory symptoms continue, you know that anytime she will throw a fit. So give magnesium sulfate, all the Zuspan regime, whatever we mentioned. Consider termination of pregnancy because the delivery is more important, not the prematurity. If BP is controlled fortunately and her symptoms are down, definitely she will continue to be admitted in the hospital. Very, very strict monitoring of all the parameters, the blood pressure, alternate day checking of the lab parameters, ultrasound as far as you can pull on. Then continue with all the other measures which I have mentioned. So these are the two cases which I have put there. So the story as it is today on prediction of preeclampsia. So these are all the references which I have taken, and I have tried my level best to make my presentation as interesting and as possible with best of my knowledge. I stop sharing here. Thank you one and all for the patient listening.
What wonderful comprehensive talk on hypertensive disorder in pregnancy. Rekha ma'am, as usual, it was clear eyesight about hypertensive disorder. We have come across toxemia of pregnancy till hypertensive disorder. The basic two classification is like early onset and late onset, which classifies in regards to our practice clinically. Very important is early detection, but rather than going for, as according to my opinion, rather than going for so many investigations, we should go and go for a justice HDP score. Like HDP score is such a wonderful score, we can predict very early that
Yes.
she will go for it. And according to the score, the the marks are given, and then the prescription is like aspirin and calcium. It lands up with the treatment
Yes.
also. As you submit the reports, the treatment comes. So it's very easy. Even ASHA, auxiliary nurse midwife, a simple MBBS medical officer does this justice score. Just give him that information and he does do it for you all. So I just wanted to more stress upon justice score.
Dr. Rekha, that was really, you covered a very, very wide range. We are running 15 minutes late, so I don't want to say too much. But on the Fetal Medicine Foundation website, there is a comparison of what you can do for prediction. And if you just take the maternal characteristics, height, weight, BMI, and blood pressure twice, along with the uterine artery PI, prediction is possible in 90% cases without any biochemical markers. And you can start Ecosprin 150 milligram and actually do a lot of help to our people. So it's not a question of a lot of biomarkers or this or that. It's basically the will of all of us to actually do it. To see that our staff is taking the blood pressure correctly, the height and weight is correctly measured, the BMI is calculated, because everything is there on the mobile. BMI calculation is no big deal, but it has to be enforced basically. So that's what I think. It was really very excellent. You covered from the most mundane to the most advanced. Thank you so much. Thank you, Dr. Monica, for giving me an opportunity to be here.
Yeah, I put the biomarkers as the completion sake, and I'm sure that all of you do agree with me that it is a clinical catch should be at the clinical level, like the checking the blood pressure, catching her symptoms, and checking the obstetric part, like IUG, early IUGR, etc. Thank you.
Thank you for a great talk, and thank you for the wonderful chairperson's comments, Dr. Asha Jain ma'am and Dr. Varsha Lahare. I'm so grateful to both of you for gracing the first session with such aplomb. Thank you so much.
Thank you, Dr. Monica, for giving me this opportunity, and Dr. Asha and Dr. Varsha for chairing the session. Thank you, one and all.
Thank you, Rekha ma'am. Thank you.
Thank you so
Hi,
much.
Dr. Picky. Nice to see you there. Yeah, thank you.
Thank you, ma'am. And now I request Dr. Neetu to start the second session, please.
Now, thank you so much, ma'am. Now we will move ahead to our second session. I hand over the session to my co-moderator, Dr. Purva Badkur, to carry forward the session.
Thank you, Neetu. For after this pre-eclampsia session, we have a session on focusing on intrauterine milieu of primordial prevention of diabetes, a rampant disease in India. So to chair the session, we have Dr. Shubha Singh ma'am and Dr. Namita Agrawal ma'am. Dr. Shubha Singh ma'am is presently president of Jaunpur OBGY Society. Can I have the CV, Dr. Vishal? Hello. Dr. Vishal?
Yes, ma'am.
Yes.
Sorry
you
to
can see.
interrupt. Vidya Tobi ma'am is here. Monica ma'am? Vidya ma'am has joined us.
Yes. Dr. Vidya has joined.
Yes. I joined Monica, but I was not able to connect to you because I was my some internet issues. But really sorry, I could not join at the beginning. But I don't want to come in between the scientific session, I must say.
Madam, we are in between the sessions and we are just going to start the second.
No, I just listened to Dr. Rekha, and she
madam, I
was
know you are
speaking
not
so
well,
wonderfully,
madam.
and I'm going to listen to Dr. Piki, who is very favorite of mine. Always I love listening to her.
Thank you, ma'am.
And I congratulate you for such a wonderful session. Dr. Manoj Chelani is there, and she's a national coordinator. And I congratulate Bhopal OBGYN Society and such a dynamic team you have chosen. And the topics are very nice. And that's why I am there in this session till last. Don't worry. Okay. So I'll be there and then I'll comment at the end. So let us continue. Thank you very much.
We call Dr. Piggy Saxena the diabetic queen of MDIP community.
Yes.
Dr. Manoj, thank you so much for this opportunity, Dr. Vidya, Dr. Manoj, and thanks a lot, Dr. Monica, for giving me the opportunity. I think Dr. Manoj's committee is doing an excellent job. We have such a
Yes, always.
He's such a great leader, gives so much importance, respect to everyone, and sabka saath, sabka vikas karte hain, Dr. Manoj. So, and it's great to see you here, ma'am. Dr. Vidya, ma'am, great to see you.
Yeah, definitely sometimes. Okay, thank you very much. Thank you, Monica, and all the best. Thank you.
Yeah, ma'am, we'll have your words after the second talk, and we are so grateful to you to join despite not being well in the morning. Thank you so much, ma'am. So over to the second session. I think speaker introduction is, yeah. And chairperson's introduction.
Yes, ma'am, chairperson introduction.
Yes, please proceed.
Dr. Vishal, please share the slide deck. We have with us Dr. Shubha Singh ma'am. Madam is presently President, Jaunpur OBGY Society. And Dr. Namita Agrawal ma'am. Madam is Secretary, Hapur OBGY Society.
Shall I share my slides?
Ma'am, just
wait.
Actually, there is some technical glitch.
Yes, ma'am, there is some technical issue.
Trying to connect his. Dr. Vishal, you are muted.
Next
Now
slide.
you can see.
Yes, we are able to see. Next slide, we want. Dr. Vishal, next slide. Dr. Shubha Singh, ma'am, she is presently owner of Harshit Medical Center Limited, Navjeevan Hospital, Jaunpur. She is owner of Advanced Charak Diagnostic Center, Jaunpur, and also director of 2 nursing schools and one 10+2 CBSE Sunbeam School. We welcome you, ma'am, to chair the session. Next,
Thank
we
you.
have with us. Next, we have with us Dr. Namita Agarwal, ma'am. Madam is presently president of Hapur OBGY Society, and she is owner of Sri Ram Medical Pelkwa, professor at Rama Medical College Hospital, and her special interest is in infertility and gynec ultrasound. We welcome you, ma'am. Now I hand over the session to the chairperson to introduce our speaker, Madam Dr. Vicky Saxena, ma'am. Over to the chairpersons.
Hello. Should I introduce?
Yes,
Dr.
ma'am.
Piki,
Yes, ma'am.
Dr. Piki Saxena is from New Delhi, LHMC, and she is Director Professor and Unit Head, Department of Obs and Gynae, in charge of Assisted Reproductive Services, Lady Harding Medical College, and winner of 34 gold medals. Wow. CS Dawn Award twice, Korean Award, Best Paper in Foxy Journal, editor of 10 books, chairperson in Infertility and Reproductive Committee, AOGT, and National Coordinator of Foxy Committee for Medical Disorders in Pregnancy. That's what we are going to hear from her. And she is an expert group member in Drug Controller General of India, convener of SIG Early Pregnancy, Indian Fertility Society, Governing Council member DIPSI, General Secretary of Board of Management of Delhi
Thank you.
Diabetic
Thank you,
Forum.
ma'am. Thank you so much for such
We
a kind
welcome you,
introduction.
ma'am. Over to you, ma'am.
Thank you, ma'am. So again, I would like to thank Dr. Monica for giving me the opportunity. And are my slides visible?
Yes, ma'am.
Okay, so today I will be talking on intrauterine milieu focusing on intrauterine milieu for primordial prevention of diabetes. So we know that now we understand that gestational diabetes mellitus is the mother of all non-communicable diseases tomorrow. GTM is not just a transient, just a minute. It is not just a transient condition, but it is recognized as a stress test for indicating physiological dysfunction. If you will see this graph here on the slide, when there is dysfunction of about 12% to 15% of beta cells in the pancreas, it leads to impaired glucose tolerance in non-pregnant patients. And in pregnancy, during pregnancy, this dysfunction of about 10 to 15% cells will lead to GDM. So as we have age advancing, this deterioration further progresses, and 2/3 of these women are going to develop GDM in the subsequent pregnancy, and 50 to 70% will develop, just a second, type 2 diabetes mellitus within 2 to 5 years. And maternal hyperglycemia, we all know, like preeclampsia, sets off a vicious cycle that affects not only the mother, but also her child and future generations to come. So it all begins in the utero. Nutrition in the early life has permanent changes. Whether this is overnutrition like in gestational diabetes, or anemia, malnutrition, preeclampsia, any of the diseases which are going to affect the mother's nutrition or the placenta are going to cause fetal malnutrition. This gives rise to the thrifty phenotype, where there is decreased growth of fetus or infant, there is decreased islet cell functions and impaired beta cell growth, and there are in utero hormonal and metabolic adaptations to maternal nutrition. All these changes occur so that the fetus can survive in utero. But after the baby is born, there is a permanent decreased beta cell function. And with age, there is obesity, type 2 diabetes, and all those metabolic syndrome that we talk about. As per the Barker's hypothesis, we all know there are developmental origins of health and disease. So maternal risk factors we just discussed. High risk factors are very, very important. I think the biochemical markers are not available as we just saw in Dr. Rekha's talk. And clinical high risk factors, obesity, GTM, preeclampsia, ART cycles, PCOS, unknown metabolic syndrome. If the patient is having any of these, we must have a high risk of, keep a high, this thing for suspicion. And we understand that this will lead to maternal hypercholesterolemia and dysfunction in the cholesterol transport in the baby, endothelial dysfunction, epigenetic changes in the baby, placental pathologies, and in utero programming occurs, and it leads to macrosomia, atherosclerosis, unknown diseases in the developmental stage. As the child grows, there is obesity, adiposity, everywhere. There is increased visceral fat deposition at the abdomen, and there are so many unknown metabolic diseases, inflammatory diseases, increased oxidative stress. And as the child enters adulthood, very early, we are seeing these days that they have all these metabolic syndromes. So maternal nutrition has a bearing on the in utero programming, results in transgenerational effects. These mothers have high fat content in the milk. They are prone to infections, immunity is low, antibiotic exposure. And as the early life exposure is also there, breastfed or supplemental feed, and they are overfed, so that leads to permanent metabolic diseases. So I want to acknowledge our Dr. B. Seshaya sir, Professor B. Seshaya. He gave the concept of DIPSI, and DIPSI is the Diabetes in Pregnancy Study Group of India, very apt test he had given us, which is done in the non-fasting state. And now sir is proposing the concept of primordial prevention of diabetes. Sir has given this concept, and we at Lady Harding had worked on this, which I will be presenting subsequently. Sir is also known as the father of GDM in India. This is the only country where there is the celebration of GDM Day, which is 10th March, because the government wanted to honor Dr. Shaya sir. It is his birthday on 10th March. So till now, we were thinking, we have read in all books and guidelines that the fasting blood glucose in pregnancy should be less than 95 and 2-hour glucose should be less than 120. But there are recent advances, and American Diabetes Association published this very important landmark paper, Should the Current Therapeutic Targets Be Challenged? And Hernandez et al. Have pooled the data of 12 studies over 45 years, and they found that normoglycemic women have a fasting of 71 plus minus 8. That is, it should be less than 80, and 2 hours postprandial, which was 120, should come down to 110. In sync with this, the DIPSI revised guidelines were published late last year in 2023, and they have given these two new categories. GDM is 2 hour 75 gram glucose more than 140, which leads to adverse fetal-maternal outcome. But now, as we saw in the previous paper, the DIPSI people also say that if the blood glucose is between 120 to 139, these people are also susceptible to adverse fetal-maternal outcome. So this is the same as this 110. So anything more than 110 is going to cause problem, even in early gestation. And the third category is early gestational glucose intolerance, which is a condition which we define between 8 to 12 weeks of gestation. And if any woman has a 2 hour postprandial, this is not 2 hour post glucose, but this is 2 hours post meal. If blood glucose is more than 110, then we need to pick it up from here rather than doing too many biochemical tests. There's adiponectin, nisfatin. There are lots of tests, biochemical tests, which are neither standardized, nor do we have the money, nor do we have the labs which can give the exact value, which has a normative for our population. So we should understand that these women are prone to develop GTM, and we need to target this group for primordial prevention. So now I'm going to talk about a very, very important concept, the fetal glucose steal. which is an underappreciated phenomenon in diabetic pregnancy. The important thing is why we have come to this important figure of 110. The renal threshold of glucose in the fetus is about 110. When the blood glucose in the mother is above this, obviously it is going to go through the placenta, cause glycosuria, and in the baby, the beta cells will be stimulated to produce increased insulin. This has been checked, and in experimental studies, it has been found that the amniotic fluid contains increased amount, high level of insulin in these patients, in these babies, and it is a surrogate marker for fetal hyperinsulinemia. At the same time, we know that fat deposition starts because insulin is an anabolic hormone, and there is fat deposition which is starting at 14 weeks itself. So the fetal programming is occurring at this time. The fetal hyperinsulinemia causes an exaggerated flux of high glucose from the mother to the fetus through the placenta. Because the baby has high insulin levels, even if the mother's glucose is a little bit high, it is going to pull the mother's glucose so that the mother's blood glucose will come out to be normal, but at the cost of the baby. And this phenomena is known as fetal glucose steal and can lead to intrauterine programming of fetal pancreas, which develop at about 10 to 11 weeks. So as the beta cell of the pancreas develop at 10 to 11 weeks, it is important to bring down the blood glucose levels before 10 weeks by initiating some intervention. So this was a very important paper again by the DIPSI group, prediction of and prevention of diabetes mellitus and its sequelae by administering metformin in early weeks of gestation. So what they say in this paper is that at 8 weeks itself, the postprandial blood glucose should be measured. And if it is found to be more than 110, we have a grace period of 2 weeks till 10 weeks so that we can bring it down to 110. This will prevent the development of fetal hyperinsulinemia. So we wondered how to bring this at 8 weeks, how to bring it down within 2 weeks. We all talk about MNT, but it is not possible that MNT, medical nutrition therapy, just the diet is going to bring down the glucose levels so fast. So sir gave the concept that medical nutrition therapy along with a low dose of metformin, probably 250 milligram twice a day, should be continued till the end of first trimester and even thereafter, so that the glucose levels are brought lower than 110 to prevent this intrauterine programming. This concept which sir gave of primordial prevention and prediction of GTM by this test, we did this study and proved it by our original data. So what we did in this study was at 8 to 11 weeks, we did the postprandial blood glucose of the woman. If it was found to be higher than 110, we found that 93, that is 95% of these women developed GTM. Whereas if the blood glucose at this time was less than 104, it was only 4.3% women out of, that is 4 out of 92 who developed GTM. So this clearly shows that what sir said, that 110 and above leads are women are prone to develop GTM has been proven. So the area under the curve, ROC curve, was 0.969. You can see here how well this is capturing the woman who will be developing GTM. And you can see here the sensitivity, specificity, positive, negative, predictive value, and diagnostic accuracy was also very high, more than 95%. Also, what I've not shown here, but we found in our study was that these women had a woman with blood glucose more than 110 had significantly higher birth weight of the babies, and the rate of cesarean sections was also very high in this group. So the next thing that sir had proposed, prevention of GTM in the by giving metformin in women having early gestational glucose intolerance, that is postprandial blood glucose more than 110. So here we are still doing this study, and it has just got completed. In the metformin group, there were we enrolled the woman who had blood glucose more than 110, at 8 to 10 weeks. And to one group, we gave metformin. To the other group, we did not give metformin. So the women who were given metformin, only 1.6% developed GDM. Whereas the women who were not given metformin, 84% developed GDM. So the results so far indicate that metformin significantly prevents development of GDM at this age. There is always a confusion and a big controversy whether metformin can be given in the first trimester or not. So I would like to, you may be knowing, but I will again like to re-emphasize that the regulatory body of Europe, which is the most stringent body, regulatory body across the world, has given approval to glucophage for being used as the first oral anti-diabetic drug and it can be used safely from conception to birth. So this approval was granted on the basis of Merck's own study, the CLUE study, which is a big published study. Sorry. So these are the very important, the ACOG, WHO, DIPSI, IAD, PSG, ADA, NICE guidelines. So all these criteria are available across the world, but we need to have a uniform policy. And whatever the Caucasians may be doing, we need to follow some tests, some guidelines which are developed by our country and for our country. It should be a make in India type of thing. So this two-step approach anyway, which the ACOG advocates, will miss. It has been proven and seen in several studies that it will miss approximately 25% of the cases. So universal testing for GDM is very, very important. As soon as the woman comes in the first trimester, we give her 75 grams of glucose in 1 glass of water. And if it is found to be more than 140 after 2 hours, she is labeled as GDM. However, if she is not found to be GDM at this stage, we should again repeat the test at 24 to 28 weeks, because at that time, there is maximum load of glucogenic hormones, and in high-risk patients, also wherever possible, repeat it at 30 to 32 weeks also. This is the only test. Just imagine when we have to go for a fasting lipid profile or sugar, it is so difficult. And for a pregnant woman to come to the hospital with nausea, hardly any patient likes to come in a fasting stage. So this test is done irrespective of fasting stage. Even if she is fasting, test can be done. If she has eaten something, still it can be done. And there are less chances of the patient being follow-up. It is easy, convenient, cost-effective. And another very important thing is that this is the screening as well as a diagnostic test. The other important thing is that it can be done as a point of care test. Again, proven by the DIPSI group that capillary blood glucose, which is tested by a plasma calibrated glucometer, is good enough. It has a good sensitivity and specificity as comparable to the venous sample. And this is endorsed by FIGO and also by the national guidelines. This is another very important device which has come in use, the flash glucose monitoring. This is a small thing, a 10 rupee coin like a sticker sort of thing, which is stuck on the upper arm, and it measures the interstitial blood glucose very frequently after every 20 minutes. And you don't need to prick the patient. You don't need to send the sample to the lab. And if you ask the patient to maintain a food diary, or you do it for yourself, I've tried it for myself. It gives a very good idea when you are having high glucose, after how much time, what is the food which is going to give rise to hyperglycemia. So the hyperglycemia is depicted at this yellow and hypoglycemia as this red one. So we manage this patient in diabetic ketoacidosis with this. Of course, we were sending the blood glucose also because the patient was in medical ICU, but you can see how nicely it is depicting what is the average blood glucose, how much time of the day it was below threshold, and how much time of the day it was above threshold. And also it gives an idea about how high the levels are. So this is a very important, good tool, and it is not very expensive. For the patient, it will cost about 2,000, 2,500 rupees for 14 days. So at least it is very good for education of the patients. And we did this thesis in Lady Harding, where we evaluated this, and we also did self-monitoring of blood glucose with glucometer, and we found that the patients were very well educated when we used this. 1/3 of the duration of hypoglycemia was missed by glucometer, which was picked up by this, and the night-time hypoglycemia, because we do it in the fasting state, pre-meal, and 2 hours post-meal. It doesn't capture the whole 24 hours profile. So in this, we found so many women were having hypoglycemia and hyperglycemia, which were being missed. And also it gives an idea about glycemic variability, which is the fourth dimension of hyperglycemia or hypoglycemic variation. And as you can see here, the glycemic variability is nothing but maximum blood glucose level and lowest blood glucose level. If this difference is a lot, that means glycemic variability is a lot. And that is why we are talking about 3 major and 3 minor meals, so that when the patient eats, the levels do not become very high and in between very low. If she takes 3 major and 3 minor meals, then the average glucose levels are going to be within normal. Another important thing is telemedicine. We started using it during COVID, and we found it to be so useful. In the government hospitals, we have Ease and Jeevni, otherwise WhatsApp, internet, and I think it is a very useful tool. The patients can send their glucose levels. We can do we can take a class, and all the patients can be given nutrition counseling, how to do glucometer monitoring, how to what are the risks and complications. Any problem the patient is having, she can write a message. The doctor can fix up a time and talk to her regarding that. So another thing is that we all know that Indian women we are focusing on intrauterine programming. So we have to detect maximum number of women. In India, we have no choice. We have 11 times higher risk of developing glucose intolerance during pregnancy because of the high insulin resistance. Therefore, we have to cover each and every woman. Like Madam was just talking about another very important thing, blood pressure, blood sugar, HP. These 3 things are the most important. And in the mobile, we need to teach them how to calculate their BMI. We need to give them targets. What is hypoglycemia, hyperglycemia, what your target blood sugar should be, and what your target blood pressure should be. And every patient, I agree with Dr. Rekha, every patient should buy anyone who has developed hypertension during pregnancy. It is a window, it is a stress period. These patients are definitely going to develop hypertension and diabetes and metabolic syndrome later on. So it is a good idea. The whole family can measure the blood pressure, the blood sugar with this. And as we know that any time the woman is coming to us, even if she's coming to us at the time of delivery, first trimester, second trimester, third trimester, whenever we get a chance, even during delivery, if we are able to catch this woman there and do a glucometer testing, find that she's GDM, Dr. Monica is going to talk about preconception, interconceptional screening and counseling, which is a very, very important period. At least we will be wiser. We can tell her about how to prevent diabetes in the next pregnancy, how to prevent how to take care of herself during interconceptional period. So we should know that nearly 62% of women have hyperglycemia even before 24 to 28 weeks of gestation. This important, another study by Dipsy Group has shown that before 12 weeks, 41% patients were having hyperglycemia. And between 13 to 23 weeks, 20%. And even after 30 weeks, 20% developed GDM. So we should not miss any chance to find any person who has hyperglycemia. This is our study, which we did in Lady Harding to compare the diagnostic accuracy. You know, the endocrinologists, I go in a lot of medicine and endocrinology conferences also, but they look down upon DIPSY, although it has been recommended by the national guidelines. Therefore, I want to show these 2 important studies in all my presentations because it is evidence based. It is not just what Sir has says we have blindly followed. So in this study, we enrolled 800 women And we compared the DIPSI test with WHO GTT and also with HbA1c. We, at that time in 2017, we found the prevalence to be 6.27% and the sensitivity, specificity, kappa value, that is the agreement between WHO GTT and DIPSI test, was 0.868. It is extremely good. So the DIPSI test is scientifically proven. This is another of our study where we did this study in 1,029 women, and we found that we compared the DIPSI criteria, diagnostic accuracy of DIPSI criteria, with the ACOG criteria. ACOG criteria has not changed over last 30 years, and they have maintained the same that we used to read Carpenter-Kuster and NDDG. Even the American Diabetes Association advocates that this test or IDPSG should be done. So we thought that we should challenge and we should see how accurate this one is as compared to our DIPSI. So what we found was, this is very interesting. The prevalence of GDM by DIPSI test was 10.4. By Carpenter-Kuster, it was 6.4. And by NDDG, it was only 3.1. And mind you, Carpenter-Kuster and NDDG are the two criteria advocated by ACOG. And you will just agree with me that this NDDG missed nearly half of the cases which were diagnosed as GDM by their own Carpenter-Kuster. And ours is the first study to show that women with GDM diagnosed by DIPSI criteria had a significantly higher rate of cesarean section, significantly higher mean weight and macrosomia as compared to the normal glycemic woman. And the diagnostic accuracy of DIPSI as compared to these two tests was also more than 95%. So again, this proves that our DIPSI is one of the best tests and should be definitely followed in all centers in our country. So postpartum care, which Dr. Monica will be talking about, I will not go into details, but this is a very, very important period. And the pregnancy, it offers a window of opportunity to establish services, improve health, prevent intergenerational transmission of NCDs. We have to emphasize during antenatal period at the time of discharge that all these women need to come back at 6 weeks, because as soon as the placenta is out, the glucogenic hormones are gone. So their blood sugar levels will come down. But we need to counsel them that they have to come after 6 weeks and then subsequently every year till a whole of their life, because they have a high chance of developing GTM. So lifestyle prevention measures, metformin, Vidagliptin is a new thing, and pioglitazone. These three things are being now tried. Lifestyle management, we already know, to prevent GTM in the subsequent pregnancy and diabetes later. So it is very also important to check for infection, support breastfeeding, because breastfeeding will lead to consumption of calories, which will bring down the blood glucose in the mother and also help her to lose a lot of weight, because retention of weight gain is another very big risk factor of development of GDM or diabetes later on. And wise on spacing, use proper contraception, preconception counseling, I think is a very, very important topic which Dr. Monica will talk about, because if we are able to optimize this, all these metabolic parameters at this stage, she will not have any complications. And retesting at 6 to 12 weeks and future glucose monitoring. Another, I will just, this is my last slide. We are doing, and we have just finished this last study, the aiming for universal coverage. We are comparing post-delivery in hospital at 2 or 3 days, we are doing WHO GTT. And again at 6 to 12 weeks, we are comparing in the same patients. Because at 6 to 12 weeks, you will all agree with me, whatever counseling we do, hardly any patients, 20 to 30 patients, even when we are running an exclusive postpartum clinic, hardly 10 to 20% patients are coming back to us. So if we are able to do this test at to second or third day, we will be able to detect most of the dysglycemia after pregnancy. And we found the sensitivity, specificity 86% was the sensitivity, 96% was the specificity, and diagnostic accuracy was nearly 90%. So this is a good test which can be done when the patient is still admitted with us, because it has a good accuracy as compared to 6 weeks, and we can start her on medical nutrition therapy or metformin or whatever, or refer her to the physician. All those things can be done at this time itself. So I would like to conclude that hyperglycemia is a major global health problem. The world at present is facing a slow motion disaster, and 2 of the 3 deaths globally are attributable to non-communicable diseases, which are programmed and imprinted during pregnancy. We know that it all begins in the utero, and we need to focus on the fetus for the future. Diabetes diagnosis and management during intrauterine period may help to prevent the tide of diabetes and NCD pandemic. I thank you all for a patient hearing, and I again thank the organizers for giving me a chance. These are some of my books on diabetes and other things. So I thank you for a patient hearing.
That was excellent talk, Dr. Vicky. But I have a few questions. Nowadays, they are combining metformin and myo-inositol together. What is your opinion for that?
I will not opine on this because there are hardly any studies. Until the
Okay.
time we get evidence, we have some substantial, original data with which we can prove. Because pharma companies, they advertise anything and everything. So taking so many, although I feel myo-inositol is a food additive only. It is not in the category of drugs. It has not gone to DCGI, which is the Drug Controller General of India, but it has been approved for use by FSSAI. But till the time we have a robust data, I would not like to give my opinion. I have not used the combination.
Thank you so much. It was excellent talk. Really
Thank you.
academic based. Thank you so much.
Thank you.
Now moving forward, ma'am, can we move?
Yeah, please.
For the
please.
next session. Yes. Now, for the next session, I hand over the session to Dr. Nandini to introduce chairpersons and speakers.
Thank you, ma'am. Our next session is by our own speaker, Dr. Monica Singh, ma'am, and she will be delivering her talk on pre and peri-conceptional care, which is a window of opportunity. The session will be chaired by Dr. Ritika Mathur, madam, and Dr. Shashi Srivastava, ma'am. Dr. Ritika Mathur, ma'am, she is the president of Kota Offline Society, and Shashi Srivastava, ma'am, who is the immediate past president of Bhopal Menopausal Society. Unfortunately, Dr. Snelata ma'am could not join us. Dr. Ritika Mathur ma'am, she has been graduated from the esteemed SMS Medical College. She is a postgraduate from RMT Medical College. She is a specialist for art of vaginal delivery, and she has special interest in high-risk obstetrics. Our next chairperson is Dr. Shashi Srivastava, madam. Madam is director at Saurabh Nursing Home in Bhopal. She is a lifetime member of Indian Menopausal Society, the PCOS Society, and FOXY. She has an area of interest in recurrent pregnancy loss, sonography, PCOS. Madam has been a pillar of strength and a great support for organizing our recently organized VPCon National Conference. She has been a guiding lamp for us. Thank you so much, ma'am, for joining us. And I will request both of them to kindly introduce our speaker for today.
Good evening, everyone. I'm very happy to introduce Dr. Monica Singh from the city of Lake Bhopal. It's a beautiful city, and I've shopped a lot from that city. I've got a few relatives there. I really like your city. And initially, my daughter joined at GMC Bhopal. If I would have known all of you, I would have sent her there. Presently, she is pursuing her MBBS from Indore. And Dr. Monica, she is working as a professor at LNMC Bhopal, and she is consultant at Bhopal Fertility and Endoscopy Center. She has been awarded the Dronacharya Award. She has been the star of SR. She is the VP of Bhopal OG Society, and she is also the VP of the Menopause Society Bhopal. She has been a managing committee member of SR, West Zone Coordinator of Medical Disorder Committee.
Thank you, ma'am. Thank you,
And-
ma'am. Thank you, ma'am.
She has got many international presentations, chapters, contributions, and national talks to her credit. The list is endless, but I think I should not take much of your time, and I think you should start with the session.
Thank you so much, Chairperson, Madam Nabita ma'am, and Dr. Shashi Srivastava ma'am, for chairing my session. And now, in continuation with the wonderful lectures we just had, I would like to take forward the flow of talks to the third important talk, which would be on periconception period. And are my slides visible?
Yes.
Yes, ma'am.
madam. Yes, ma'am.
Yes, it is visible.
So this is a very interesting topic, and I must give due thanks to MDIP committee, because it was my entry into MDIP committee. This is the first talk I got. Pre and periconceptional care, a window of opportunity. And I must confess, this was a new topic to me. So whenever you have something new to speak on, you try your best that you know everything about it. In that process, I read a lot, I presented. So this is a talk I'm giving today, because we know about prenatal care, we know about intranatal care, we know about postnatal care, but what is periconceptional care? The periconceptual period has got a very interesting definition. This is actually a 5 to 6 months period, almost more than half a pregnancy, when a woman can decide how her baby's future health and future life would be, which is so awesome, because here it starts with oocyte development, the fertilization of the gamete, the formation of the conceptors, that involves all implantation and all the procedures, the embryonic, embryo endometrial dialogue, and then development of that fetus up to the 10th week of gestation. 10th week of gestation is another very important sonographic marker, because it marks the closure of the secondary palate in the embryo embryologically, and also it marks the beginning of the placenta formation, which is visible on ultrasound. So I thank Dr. Purva for this article. This is a beautiful article, review article published very recently in 2023, wherein the human periconceptional period has been correlated. The maternal embryonic space has been studied in detail in this paper, Physiology, how it correlates with health and disease. And this has a very beautiful diagram wherein you can see a ball of cells known as the embryo, the blastocyst, literally bouncing on the endometrium. And before the mother accepts the embryo as her own, it has to pass through a lot of, crosstalk. There is a dialogue. The endometrial microbiota jumps in. The decidualized endometrium has got number of cytokines and factors which examine the embryo. Then there is something called endometrial receptivity, which opens up a window. And finally, this embryo, it adheres to the maternal endometrium and starts invading. And there's a role also to play by the myometrium at the bottom there, because this is the time when probably it stops its contractility for some time. So the embryo implants very nicely. Now, periconceptual period, why don't we know about it? Because it has been understudied. And who was the scientist who actually gave a great attention to it? This was Stigers and Tennyson. This group has been studying it in the early 2000s till 2010. And now their study and their literature has been made even more easy to understand, because of the sophisticated 3D ultrasound we have. Like everything we study, we can visualize it on our beautiful ultrasound machines. So this period of periconception is heavily ruled by molecular events, and every molecular event can cause epigenetic modification to the DNA of the oocyte, because the period of ovarian follicular development is very long. It's an extended period of 12 to 14 weeks, during which epigenetic modifications of the oocyte, which is going to get fertilized, can happen. So that is why you have to keep the external influences like maternal lifestyle, her exercise, stress, nutrition, very optimum if you want a good embryo to form. all of us human beings are the result of a mix of two entities. We have got a mixture of genetics, which is nature, and environment, which is nurture, in equal measure. So the periconceptional period actually is a crossroad or a choraha between reproductive medicine and obstetrics, where nature, that is genetics, and nurture, that is environment, come together at the beginning of life. Infertility specialists, they seek to optimize the pregnancy success by the first trimester outcomes. That is what is their main aim, that the first trimester should go well. Whereas the obstetricians, they prioritize the diagnosing, treating, and preventing of second and third trimester obstetric complications, including preterm labor, preeclampsia, fetal growth disorders, and fetal death. We have been, listening to these talks of HTP and diabetes, so from such good speakers. But traditionally and logically, infertility specialists and obstetricians, we work in tandem with each other, parallel with each other. What we need to understand is that maternal and fetal health, we have to start monitoring at the beginning only, at the time of embryo implantation. And once we give a lot of leverage and weightage to this knowledge of periconceptional period, this can shift the focus of reproductive and obstetric care to a very early time frame. So when we shift our care to earlier time frame as to a woman who is trying to conceive, because more and more women are educated nowadays, so they are coming for pre-marriage counseling, preconception counseling. So many of these educated and tech people are coming, whether our genetics are okay. If we do it at an early time, we can avoid and prevent significant neonatal maternal morbidity, mortality, and healthcare cost burden later on. So, this pregnancy is a continuum period of periconception, which begins with blastocyst attachment to the endometrium. And as I mentioned earlier, there is adhesion, apposition, invasion, and formation of placenta. And this period sets the foundation for child and mother's health even later on. And this is also the period where you can prevent the downstream pathologies at this stage if you intervene. So this period, you not only study about the pre-implantation human embryo, the maternal endometrium, but we also have a very important which maternal decidua and decidualization plays, the periconceptional maternal embryonic interface and dialogue, the importance of endometrial microbiota, and finally the myometrium. Does it have any role in the to play? Especially if this myometrium is riddled with fibroids or probably a lot of adenomyosis, then what do you do? So all this periconception period of time span of 14 weeks before the onset of pregnancy to 10 weeks after conception. This is nearly 24 weeks or 5.5 months. This is a mixture of complex molecular biological processes and epigenetics. It is during this critical period that all these processes of fertilization, implantation, and placentation take place. And this is therefore pivotal to human reproduction in general and pregnancy outcome of all types. So this is just a diagrammatic representation of gametogenesis, fertilization, implantation, embryogenesis, and placentation, and the stages of implantation as far as embryology is concerned. We should all know that the embryo which implants inside the receptive endometrium is actually the hatching blastocyst. So that's the reason when we are working in the IVF lab, sometimes we disturb these processes. Sometimes we are doing a day 3 transfer, a day 2 transfer, a late hatching blastocyst transfer. So as Dr. Manoj would agree, and all the IVF specialists out there, that is sometimes, your pregnancies, the attempts might fail because you might not reach that window of opportunity or the window of implantation which this embryo is seeking. So this is another very beautiful diagram from the same physiology article, which tells you how this communication occurs across this endometrial fluid. So this endometrial fluid, which is present there, sorry. This endometrial fluid, which is present between the embryo and the maternal decidua, is known as the uterine milk. And the uterine milk has got so many autocrine and paracrine effects on the developing embryo and the implanting embryo through micro vesicles, through ATP levels. You can see transcriptomes. You can see DNA, RNA, microRNA, adhesion and anti-adhesion molecules, cytokines, chemokines. Means it is a chapter in itself. This article will take you a whole day to read, but it's a beautiful piece of work. And ultimately, we are looking at this couple should have good fertility, fecundity, and should not miscarry. And what is a time to pregnancy? Because the periconceptional period is also very important as far as fertility is concerned. So before we know what is fecundity, we should know how it is defined. So we all know fertility in a couple is the capacity to establish a clinical pregnancy. But the fecundity is the capacity to have a live birth and to give birth to a healthy baby. That periconceptional period has to be very good. And also very important is the time to pregnancy, or TTP, the time taken to establish a pregnancy, which is measured either in months or cycles. So these three things are very important as far as periconceptional period is concerned. And now there was this great researcher from Sweden, I think. No, she's from Netherlands, Dr. Oosting, who published a beautiful article in RBM Online. And this was published in 2019. The impact of maternal lifestyle factors on periconception outcome. This, she did a systematic review of observational studies. And what the key points they found was that the main risk factors for reproductive health issues like subfertility also originate in the periconceptional period. Moreover, the capacity to have a live birth in a particular woman has got an inverse correlation with her use of smoking, alcohol, substance abuse, and dietary habits. Similarly, the time to pregnancy also shows a negative correlation with increasing BMI. Furthermore, the risk of first trimester abortions is also seen to be higher in smokers, alcohol, caffeine consumers, and there's a particular level of caffeine above which it is harmful. You should not stop caffeine altogether. Advise the woman to do so. And definitely BMI has a role to play. Now, interestingly, the guidelines don't say so, but vitamin supplementation use shows a decrease of first trimester miscarriages. Therefore, definitely maternal modifiable lifestyle factors will affect the periconceptional outcome. Now, coming to history, the history of periconception period and the correlation of in utero milieu to adult life disease of that particular fetus has got a very interesting history. In 1976, it was Ravelli who showed that obesity is a composite determinant of poor lifestyle in those individuals who had been exposed to starvation in utero. So they studied these women who were pregnant during Second World War in the 40s. There was a famine, and these mothers were starved. So the offsprings who were exposed to starvation in utero in their mothers, they grew up to be obese children, and later on they were prone to have increased risk of metabolic and cardiovascular diseases when they grew up. This gave way to an epidemiologist called David Barker from UK. In 1990, he postulated that even low birth weight in offspring is a proxy for poor prenatal and intranatal maternal nutrition, and this has got a correlation with the risk of coronary artery diseases in adulthood in that child, and also other NCDs like obesity and even certain cancers. So this fetus inside the uterus has got some plasticity. So once it is in the uterus, it makes a plan to adapt to the environment it will enter after birth. So this hypothesis of David Barker was known as FOAD, or fetal origin of adult disease. But now there is even somebody is challenging this hypothesis, because there have been certain groups where this hypothesis was not applying, but still to make theory simple, we have stuck to this. But now there is a challenge to this theory, which is already in print. Now, a little bit about endometrial microbiome and is it related to infertility and all the pregnancy complications? So, this is known as dysbiosis. Whenever there is imbalance of microbial population in the endometrium, that is known as dysbiosis, and this alters the host microbial interactions. And this imbalance also leads to imbalance within the fetal gut and maybe a positive factor for chronic inflammation later on, immune disorders, metabolic syndrome, cancers, and even mental disorders such as autism, depression. Now, you will say, how can the early life gut microbiota of the fetus lead to autism and neurological problem? But it does, as it modulates also the fetus immunity modulation metabolism. So, this is something called the reproductive brain axis. So there is a traffic between the fetal gut and the fetal brain. So there is an exchange of molecules. This is modulated by microbial metabolites. So this is known as the microbiota gut-brain axis and is a causative factor of several neuropsychiatric disorders also in the baby and the young child as the child is growing up. So we have to be aware of these serious neural conditions which can arise through microbiome disorders like Alzheimer's, Parkinson's disease, autism spectrum disorder, several ADHDs, and amyotrophic lateral sclerosis. Coming to nutritional deficiencies, we have got metabolic, we'll remember from our biochemistry, that why does the lifestyle of parents to be affect the periconception and the baby. This happens because of derangements of one carbon metabolic pathways. This is a very important metabolic pathway in our body, which utilizes methionine, vitamin B12, folate, and it drives the synthesis of proteins in the body, biogenic amines and lipids, which are required for early growth. And also these are actually the regulators of gene expression in the body. So when there is a nutrient deficiency in the background, it can contribute to subfertility, early miscarriages. It compromises the offspring health, the baby's health. And whenever we are doing ART and using procedures in ART, we can also disturb the metabolic pathways in a very different way by the drugs which are used for stimulation, by the procedures in the lab, by the embryo manipulation. We can actually contribute to epigenetic changes and poor pregnancy outcomes. The most important nutrient, which I would like to mention, is maternal DHA, which is docosahexaenoic acid. This is an omega-3 fatty acid. So our most important concern is that why is maternal DHA so important? Because it is directly proportional to the infant's neurodevelopment. As you can see, the delivery of DHA from the DHA-containing foods, which the mother consumes, is transferred to the embryo right from the beginning to the postnatal stage. So let's start from the first trimester. When first trimester mother eats these the DHA-rich foods, so I just made a list. Though the fish lovers are the most benefited because all fish are rich in these omega-3 fatty acids, but we've got supplements also. But the vegetarians can get rich DHA from walnuts, from berries, from avocado, which is now available, from chia seeds, from flax seeds or alsi, from papaya, and from oranges. The DHA which is available from fruits is not very much utilized by the body. So it is advisable in vegetarians that they take a supplement. So in first trimester, when we take this DHA, there is vessel remodeling and angiogenesis, which leads to, a good embryo implantation because of the immunocompetence, because of angiogenesis, and because of the decrease in the reactive oxygen species factors. In the third trimester, this DHA transport and metabolism is through placenta. And in the postnatal stage, the DHA transfer from maternal side is through breast milk. Now, breast milk is a very rich source of DHA. I've been taking part in a lot of breastfeeding programs also lately with the state of Maharashtra, and we cannot overemphasize that breast milk is like virtual amrit for the baby, and it leads to good neurogenesis. Neuronal survival is there, synaptogenesis, synaptic plasticity, ROS inactivation happens. There is increase in the neuroprotecting gene expression, decrease in the inflammatory markers. And so these are all the advantages the breastfeeding mother is passing to the baby, and they have a direct relation with the fetal neural development. A little bit about maternal obesity. We are seeing more and more of obese mothers nowadays. So we have to explain to the woman, though we don't have to stress her out, that there is a negative influence on female fertility of obesity. This happens because there is dysregulation of the HPO axis. The HPO axis is disturbed, it leads to ovulatory dysfunction. This also has got excessive gestational weight gain during pregnancy. Suppose it is 15 kg, 20 kg, 25 kg, we are seeing nowadays. This is also a key predictor of childhood obesity and metabolic complications of that child as it becomes an adult. These are known theories. Now, these children are also prone to have cognitive defects, externalizing problems like ADHD, and internalizing psychopathy in childhood and adolescence. So a word of caution is required for those mothers who are, not aware of the dietary pattern during their pregnancy. And of course, a word about how 3D, 4D ultrasound has changed the periconceptional assessment, because they have given us large databases on what is normal, what is abnormal fetoplacental development. We are doing Dopplers so liberally. So there is better understanding of the pathophysiology of early embryonic development and how it affects the pregnancy and the afterbirth. A little bit about cigarette smoking. Now, this is the real poison, which is not only active smoking, but the smokers don't realize how much of passive smoking they are causing. So this contains nearly 4,000 toxic compounds. This is the whole list. So these constituents, they affect the follicular microenvironment of that woman when the eggs are forming. The hormone concentrations in the luteal phase are all disturbed. This shortens the luteal phase. Once the luteal phase is shortened, the corpus luteum is deficient. So there are early abortions, there is subfertility, there is reduced ovarian reserve, and these women may have lower AMH concentrations as compared to non-smokers. And there is also a decline in the capacity to have a live birth, that is fecundity. This is also definite correlation with cigarette smoking, impaired endometrial maturation. You will not get good IVF results. The placenta of these women is smaller, and there is an increase in the risk of first trimester miscarriages. This is directly proportional on the number of cigarettes smoked per day. So though the best thing would be for the woman to quit smoking, but like even decreasing the number of cigarettes per day will work. Now, there is also a very important paper which was published in Risk and Protective Environment Factors Associated with Autism. Now, autism is also a complex condition of early childhood onset. This is again an interaction between genetics, that is nature, and environment, that is nurture. Because all these periconceptional problems like advanced parental age, ART techniques, poor nutritional status of the woman, maternal infections, diseases, environmental chemicals, toxins, medications, pesticides, they all have a significant impact on the three biologically relevant time windows for brain development for the fetus, that is periconception, I've told you 24 weeks, prenatal, and early postnatal. So autism is also the final consequence of cascading events which impact the brain development right from preconception to early postnatal life. And in these individuals in women who have already got an autistic baby, the genetically susceptible sibling or the twin or the second baby, it reaches a threshold point to go into ASD, this autism spectrum disorders. So we have to counsel the woman. And these are all the risk factors in the preconception period which come into play. Number one, advanced maternal age. Number two, the use of ovulation induction and ART procedure, which is again a risk factor. And definitely in the preconception period, exposure to toxin, nutritions, and medications. And these are the risk factors in the periconceptional period and the prenatal period. Again, the toxins, again, she's consuming pesticides, phthalates, heavy metals in the food, the processed food or in the foods which are fruits and all which are in the storage, cold storage. And of course, if she is she is taking medication, substance abuse, and some maternal infections which she's exposed to. So these are the, this is a long slide, so I'll not be going through. These are all the environmental risk factors during conception, prenatal, and early postnatal, which make the woman vulnerable to the autism spectrum disorders or the ASDs. And these are, again, the infections and the types of diseases she might be having, whether it's GDM or depression or stress, which can lead to ASD in the fetus. So these are the recommendations in the periconceptional period. Since we are late, I will not go through the details, but you have to monitor the diet of the woman, give proper counseling about daily folic acid consumption, vitamin D intake, and from natural sources, and reasonable exposure to sunlight is a must. And the daily folic acid intake has to be the proper quantity, preferably preconception, and a constant intake of vitamin D and iron. So this is how there is, the environmental factors, how they have an effect on ASD is right from conception, an autistic sibling, advanced paternal maternal age, coming to maternal physical condition, obesity, diabetes, exposure to even the traffic-related air pollutants, pesticides, autoimmune disease, ART, prenatal infections. Now, birth by cesarean section is also a risk factor because I have not touched into it. When you do a cesarean section, you disturb the endometrial microbiota even more. Labor induction, anti-epileptics, antidepressant medication in the mother, delivery complications, and low birth weight. And the protective factors are all these: melatonin, vitamin D supplementation, omega-3 fatty acids, folic acid in optimum quantity, iron supplementation, and definitely a big yes to breastfeeding, exclusive breastfeeding for 6 months minimum. So this periconceptional period of 5 to 6 months or 24 weeks is a prolonged period of time during which prospective parent has this window of opportunity, which is the topic of my title of my talk. This window of opportunity is a very big opportunity to adopt measures in order to make the lifestyle modifications such that they have a good pregnancy outcome. Future research should focus on preconception care because we are already on the brink of so much of GDM. Dr. Piki told us about the diabetes epidemic which is happening. So preconception care is the way forward to optimize the health of our future generations. Thank you very much. Thank you for
Wonderful, Monica. You had done wonderful job. Not only the series, webinar series, this is also the Symbiosis series is one of the unique series of webinars where you have get together. I meant to say you have a lot of galaxy star all over India in the different topics, and you also done the great job. Wonderful. How the preconceptional period is a very important for every woman and every gynecologist to address their patients. So it is a eye-opening session for everyone.
Thank you.
You have done wonderful job.
Thank you so much, Shashima.
I also give my best wishes to Dr. Preeti for their birthday wishes. Happy birthday, Dr. Preeti. Wonderful session, Monica. You are a good academician. You are not writing the various articles in the journal, also in the Foxy Focus, and you may go many fold beyond the things in the future.
Thank you, Shashi ma'am. It is your love for me which is speaking.
No, you are really, really wonderful. You are a gem from Bhopal.
Thank you, ma'am. Thank you so much, and thank you again. Now it is the time to deliver the vote of thanks. I would, because we are ending Symbiosis. This has been a beautiful series, and we should not be sad because we have ended it. We started beautifully, we ended beautifully, and every good thing must come to an end so that another good thing starts. So I thank all my respected dignitaries. Vicky ma'am is here. Thank you so much, ma'am, for the opportunity. And you are the reason the interest in diabetes has, become so much. Because of you, I from IVF have come to, MDIP. And thank you so much, Shashi ma'am. Thank you, Asha ma'am, for being there all the time. And Asha ma'am is again a very big support to me, though she is a contestant herself. But every time I have any problem, I just pick up the phone and call Asha ma'am. And Manoj is, of course, like my brother. Thank you so much, Vishal. Thank you, Neetu, Purva, Nandini. Thank you, Chairperson Shubha Singh ma'am and Ritika Mathur. And thank you, Team Symbiosis. Thank you so much.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Thank you.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, ma'am.
Bye. Bye.